Welcome to the 11th Annual Kountz Callender Drew Transplant Symposium, sponsored by the Gift of Life of Michigan, the Minority Organ Tissue Transplant Education Program, and Michigan Medicine of the University of Michigan. My name is Alexandria Ballard Sims. I am a program lead for today's exciting conference. I am a registered nurse that works at Henry Ford Hospital and a current student within the Doctor of Nurse Practitioner program at Wayne State University. I am honored and delighted to serve as a member of the 11th Annual Transplant Symposium Planning Committee. This year's theme is focused on equity and equality in health, in medicine, and transplantation. We'd like to extend a special thank you and shout out to our 2021 Kountz Callender Drew Transplant Planning Committee and presenters, and also recognizing the talent, program participants who support our mission. If you could not attend yesterday's live session, a link to our program book is available on our Zoom chat. The program e-booklet includes speaker schedules, bios, details on the program evaluation, and CEU information. Today's agenda is focusing on engaging our presentation of healthcare leaders, Jenn Turner-Dold, Frontline Workers Spotlight, Will Sherry, Dr. Shakir Hussein, and concluding with a panel discussion entitled, "Are You Providing Equitable Healthcare with Passion and Humility?" Our goal today is to engage our participants, and we strongly encourage and welcome all questions. Please make sure to submit your questions in the Q&A section. Due to time limitations, we will do our best to answer your questions. Comments can be shared also in the Zoom chat. Please make sure to designate your chat messages to both panelists and participants. Before we start, I'd like to go over some housekeeping reminders. We are pleased to share that, again, we have no financial disclosures among our presenters. The KCD Transplant Symposium accreditations and credit designations are provided by the Accreditation Council for Continuing Education and the University of Michigan. This information is also located in your program booklet. Also, the evaluation and certificate information will be located in your program booklet as well. And it is my honor to introduce the moderator for today's dialogue, Dr. Silas Norman. Dr. Norman is a transplant nephrologist, the co-medical director of kidney and pancreas transplantation, director of the Transplant Multi-Specialty Ambulatory Care Clinic at Michigan Medicine, and currently a member of the National Kidney Foundation of Michigan and Detroit MOTEP Foundation boards. And without further ado, I bring to you Dr. Silas Norman.
Alexandria, thank you. Thank you so much. Good morning, everybody. Thank you so much for joining us for day 2 of the 11th Annual Kountz Callender Drew Symposium. If you had an opportunity to join us yesterday, you know that we had just a fantastic lineup of inspirational and thoughtful presentations. And day 2 will be no different. We have a wonderful agenda planned for you today with a number of great speakers that will help us think and be more thoughtful about how we can take better care of ourselves as well as the communities we serve. We're going to kick off this morning with a couple of welcomes. Our first welcome this morning will be by Dory Dills, who is the Chief Executive Officer of Gift of Life Michigan, which is our organ procurement organization and one of our key partners in this team effort that is transplantation. Dory, good morning.
Good morning. Thank you, Dr. Norman. Good morning, everyone. And thank you once again for tuning into this important discussion. Since its founding in 2010, the annual Kountz Callender Drew Transplant Symposium has tackled timely and relevant topics, and this year certainly no exception. The theme, equity in healthcare, medicine, and transplantation, is an ideal we all strive for each and every day at Gift of Life Michigan and with our transplant partners and transplant centers. About a year ago, we were just learning how widespread the impact of the COVID-19 pandemic would be, particularly on communities of color. The pandemic has served as a sad reminder of the inequities in healthcare, including transplantation, that is experienced by minority populations throughout the country. Our work to save lives and remove those disparities continues. Gift of Life Michigan is committed to diversity, equity, and inclusion, and whether it be internally with our staff that we employ or how we serve the community. We firmly believe there is strength in diversity, and we are, as an organization, better together. As we make progress in other areas of diversity and inclusion, we are proud of that as well. Last week, the HOPE Act was introduced in Michigan's legislature. It would allow for organs of HIV positive donors to be transplanted into HIV positive patients here in Michigan, offering them additional hope for healing and a better quality of life. Later today, you will hear a speaker, Will Sherry, Director of Spectrum Health at University of Michigan, lead a discussion on LGBTQ+ identities and inclusion practices. We will need to continue to work together to ensure equity in our healthcare system for people of all backgrounds and beliefs, and I think forums like this symposium will help us get there. I would like to thank all of our guest speakers who continue to highlight these important topics, everyone who works so hard behind the scenes to make the symposium happen, and all of you for attending and doing your part. We will need to continue to work together to ensure equity in our healthcare system for people of all backgrounds and beliefs. I would also like to extend my personal appreciation to the many frontline workers who've stepped up so quickly to respond to the pandemic. I'm thankful for all you've done to care for and keep our communities safe and thriving. Thank you again and enjoy your conference.
Thank you so much, Dory. Next, we have a welcome from Dr. Erica Newman. Dr. Newman is an associate professor of surgery, as well as the surgical director of the Mott Tumor Oncology Program. Dr. Newman is also a leader at the hospital, both in terms of equity and opportunity for faculty, but also in improving the opportunities for quality care for the people that we serve. Good morning.
Good morning, Dr. Norman. Thank you so much. And welcome again to the 11th Annual Kountz Callender Drew Transplant Symposium. Thank you to the planning committee and to all of the moderators and speakers. This event and the topic of equity and equality in health, medicine, and transplantation is timely, necessary, and critical. So thank you from the University of Michigan and from Michigan Medicine. It is a privilege to partner with the Gift of Life and the Minority Organ Tissue Transplant Education Program, who has so astutely recognized that the gift of life is for all people, though we are reminded more so now than ever before that the gift of life is not afforded to all people. Over the past year, we bear witness to great injustices, the unequal impact of the COVID-19 pandemic with disparities in sickness and death in Black and Brown communities, the racial reckoning of the senseless murders of George Floyd, Ahmaud Arbery, Breonna Taylor, and many others, the legacy of racial hatred demonstrated in the January 6th insurrection. And just this week, 8 Americans, including 6 Asian Americans, were believed to be killed solely on the basis of their race and ethnicity. As healthcare providers, we take an oath to treat all patients equally, yet we know that all patients are not equally well. Poverty, poor health, and diseases spread along patterns of marginalization, exclusion, and race, accounting for what medical anthropologists have termed structural violence. Structural because inequities are embedded in the economic organization of our social world, often in ways that are unseen by those with privilege and power. And violence because of its impact. Killing of unarmed Black men by police or in police custody, the extrajudicial killing of Black and brown people by vigilantes, and the shocking prevalence of poverty, with 3 in 5 children in Detroit and other urban environments living well below the poverty level. These problems are our problems. These people are our people. We recognize that turning a blind eye or being passive about inequity is not a component of our excellence. Society gives our voices great strength and credibility. It is time to break these paradigms. We must forge and stay true to being leaders and best. At Michigan Medicine, we have sounded the alarm and stand firmly committed to addressing all health inequities and building sustainable systems and processes to map the path forward up and out of health inequity. We have committed to several strategic priority areas across the organization, and we are working daily to do our part to address health inequities and disparities. We aim to become a relentless ally. Racism and violence directed against Black and brown people, or indeed any member of society, impacts us all. The structural violence that disproportionately affects people of color and those living below the poverty line has become a public health crisis. And it is our responsibility as healthcare providers to address these complex social issues. We now have an unprecedented opportunity to deeply examine how we individually and as organizations can and will respond. We must condemn racism and discrimination when we see it and not go quiet. It is not enough for us to abstain from racism ourselves while allowing it to take place to our brothers and sisters all around us. We are working to put operational structures in place that will examine our daily processes and clinical decision-making for health equity. The Michigan lung transplant team has come forward as the pioneer in this space. We will pilot a new strategy with their work and with their care teams directly. This will include an assessment and ongoing training around issues like implicit bias, anti-racism strategies during transplant evaluation and decision-making around who gets referred, who gets evaluated, and who ultimately is transplanted. We are working to build a culture of equity and a sense of belonging. Michigan Medicine has become a member of the Healthcare Anchor Network. This is our opportunity for a full commitment to invest in the communities in which we live and serve. It's our opportunity to commit that we will assure and contribute to community wealth, as well as the upward economic mobility of our local communities like Ypsilanti, Detroit, and Flint. We have challenged ourselves to build the biggest and most successful pipeline program for children of color in America. We have the structure, the background, and the experience to rise up children in the state of Michigan and beyond and nurture them and prepare them to become doctors and nurses. We can do this here. We shall no longer watch social justice from the sideline. We are at an urgent tipping point in America, and we must act now to shift the paradigm of injustice. It is time for drastic changes. Conversations and the exchange of ideas like this format and this framework create cultural empowerment, and create a community of change, particularly in regards to organ and tissue donation. What an opportunity we have to move the needle. Alongside you, we at Michigan Medicine pledge to continue to work to address injustices at all levels: clinical, research, education, and in our healthcare workforce. We hope to ensure that all can have access to the highest level of health and well-being and reach their highest potential. We stand in solidarity and welcome again from Michigan Medicine.
Thank you so much, Erica, and thank you for reminding us of some of the events of the last year and also helping us to put that in the larger context of institutional and structural racism, and reminding us of our shared responsibility to make things better for the patients we care for and for the communities we serve. We appreciate you. Good morning. Next up on our agenda this morning is we are going to go to our Connect to Purpose. And we have with us this morning, Jenn Turner-Dold. Jennifer is a volunteer at the Gift of Life Michigan. She's also a Michigan Medicine lung transplant peer mentor, and she's going to share with us some interesting information and introspection to set us off this morning. Jennifer, good morning.
Good morning. Thank you for having me. I was asked to share a bit about my transplant journey that I've had. I was diagnosed in 2010, in August of 2010, by Dr. Meilon Han in the lung transplant program at the University of Michigan with an incurable disease called lymphangioliomyomatosis, or LAM is the short version. With that disease, I have developed tumors and cysts in areas of my body where they shouldn't be. It's basically like the wrong cell growing in the wrong part of your body. So I had endometriosis and polycystic ovarian syndrome, which caused me to have a hysterectomy when I was 28. And then after that, I ruptured a part of an angiomyolipoma from my kidney. And that's how we found the kidney tumors that I had. Fast forward a few more years, and then I started coughing up blood every day and was feeling like if I went to sleep, I wasn't going to wake up in the morning. So eventually I was transferred to a pulmonologist in the Muskegon area who did a CT of my lungs and came to the hospital and said, I've only ever seen this in textbooks. I think this is what you have, and referred me over to the University of Michigan, where I got formally diagnosed and everything kind of got put together for my disease. I was told at that time that I needed a double lung transplant. I was already at that point, and that it was the only option I had to extend my life. And that even with that transplant, there was only a 50-50 chance that I would get to 5 years. I was only 35 years old at that time, and I was not ready to hear that information. So we, with the help of pulmonary rehab and nutritionists, and with the University of Michigan program, we worked together and got my weight down enough to get listed. I lost 50 pounds to get listed for a transplant. And in that time also had several bouts of pneumonia and pneumothoraxes from the holes that the cyst would cause in my lungs. And so eventually I was listed for lung transplant in June of 2011. By September of 2011, I was admitted in the hospital, and they said, your oxygen requirements are too high to go home. You'll either get the transplant and walk out of here, or you won't. So that really began the next level of the fight to be here. And we did that. I say we because it was a team of nurses and doctors, physical therapists, and my family, my wife. We all fought together for me to be here. And I was transplanted February 4th, 2012. It was an 11-hour surgery. I was number 199 for a double lung transplant at U of M. And the surgery itself appeared to have gone well. And when I got out of the surgery, we realized that things were not going to be as easy as we had hoped. And my diaphragms had become paralyzed in the process of surgery. So in order to try to get off of support from a vent, they trached me and vented me, and we began the process of learning to wean off of the vent and get those accessory muscles strong enough to breathe for me. So my diaphragms have remained paralyzed, but I now breathe with my back and chest muscles and my upper abdomen muscles. So after 207 days admitted, I was discharged from my double lung transplant on April 18 of 2012 on room air. I walked out of the hospital on my own. So that was a pretty amazing moment. And the next year was pretty rough for me. I was admitted approximately 14 times. Eventually, we found out that I was just basically over immunosuppressed. And so they backed off on some of my immunosuppression meds. And then I was able to not pick up viruses as often. I did gain a lot of weight in that first year out. And it was kind of unexplained. At this point, I think looking back, it was probably my kidneys starting to not keep up with things. So eventually things stabilized out, and my wife and I decided it was time to take the next step and start a family. So now we're in 2017, and a few months after my wife got pregnant, I started coughing up blood, and my oxygen saturations were dropping again. And we kept looking at my lungs and trying to find things, but we couldn't find what was happening. Eventually, we did a chest x-ray that showed what they thought was a whopping pneumonia. And they admitted me in the hospital in the summer of 2017 and ran all kinds of tests and couldn't find any signs of an actual infection. And then after a bunch of tests, they finally found that I had a 65% leak in my mitral valve in the wrong direction. So what they saw on my chest x-ray was actually blood backing up into my lungs. So they ran several rounds of dialysis on me and pulled off 30 pounds of excess fluid in 2 days, got me as dry as they could, and then went ahead and gave me open heart surgery and a mitral valve replacement. Which of course was a little extra special because of all of my previous surgeries. The surgery went well, and 2 weeks later, my wife delivered our daughter, Avery. It was a pretty exciting time, but then with the heart failure and the kidney tumors that I already had, and the transplant meds that I've been on, that was it. That was it for my kidneys. That took out what was left of my kidneys. And I ended up starting dialysis in June of 2018. So I have been on dialysis 3 days a week for 4.5-hour runs. Each time my kidney function is down to approximately 4%. And I have been listed to try to get a kidney transplant since September of 2018. So that is our next goal, to get our life back to a sense of normalcy. I am very blessed to be the stay-at-home mom for our 3-year-old. She keeps me very active, and I keep losing weight and trying to get stronger for the next round of surgeries. It does look like my kidney tumors are getting larger again and in danger of potentially rupturing. So unlike a lot of kidney transplant patients where they leave the kidneys in, they're most likely going to take mine out. So now we're trying to figure out, can we wait for the surgery to happen at the same time as potentially as transplant? Is that possible, or do they need to be 2 separate procedures, the nephrectomy separate from the actual kidney transplant? But that is the next stage in my healthcare at the U. I'm very blessed to have survived a lot of different things that have taken out friends of mine that haven't made it to this point in their transplant. I've had CMV 3 times, RSV twice. I got shingles in the muscles I used to breathe. I got gout from the medicine that I take for anti-rejection, so bad that they thought I broke both my feet. I've had parainfluenza virus 4. Most recently, last year, I had the metapneumovirus, which caused me to come home on oxygen for the first time since transplant, and wean back off of that. And that took 9 weeks to get back to room air. But I'm very blessed. I have a huge team at the U that supports me. And I think the takeaway from my experience is that even if things don't go perfectly with your patients with the transplant, they can still have a really good life. They can still have the quality of life that we all aspire to. I have a thriving family, and I feel very blessed. Not every day is easy, but every day is good. And I thank you so much for allowing me to share my story.
Jenn, thank you so much for sharing that story. And there's so much in there, and we appreciate you sharing that course. One of the things I think is so helpful to many people out there is just knowing that sometimes things don't go perfectly smoothly, and for people to know they're not alone in that struggle. Certainly from the Michigan Medicine transplant community, we're all pulling for you, hopefully to get this kidney transplant soon and have a great outcome. And I wonder if I could just ask you to comment on one question. There's a question that says, appreciate you for sharing your journey, and wanted to ask, how has your experience as a lung transplant patient help you as you wait for the kidney transplant? And then also a question about the team that you mentioned. How has your family helped you through this process?
Well, as far as my family goes, my wife has been key, and we have developed a very close-knit, extended family that isn't biological, but is in Ann Arbor. My church has been a big part of that, and part of the First United Methodist Church of Ann Arbor. And we kind of joke that with my daughter, she has 3 local grandparents, because my family is in Virginia, and my wife's family is in Kansas. And Avery actually has one set of grandparents that one of them was my physical therapist in the hospital that got me up to transplant, strong enough, kept me strong and through transplant, and has remained an active part of our lives. Another set is from our church. And then a third set is my wife actually became part of the physical therapy team at the University of Michigan while we were trying to find another career for her. She was there for, gosh, I want to say at least 4 or 5 years. And one of the physical therapists that she worked with was actually in the birth of our child. She was part of that process. So very tight-knit group of family that supports us here. And with the University of Michigan team and the lung transplant process, gosh, Dr. Hahn is amazing, and she has been part of our process from the get-go. But it's a whole team. There's social workers that I've worked with, as well as dietitians and physical therapists, and the nurses that are there for you. Just knowing that they are there if needed is a huge relief, and allows you to have a daily process where you can kind of take a deep breath and go, okay, I'm not great today, but I'll just let them know and let them worry about it. And then I don't have to worry about it as much, because I know that they're there and they'll let me know whether to be truly concerned or not. With the kidney related to the lung transplant, I think knowing that the medications, we've already adjusted my medications so that I'll be able to smoothly go from lung transplant to kidney transplant. We switched a couple of my anti-rejection drugs to make that so that once the transplant happens, we can stay on those same medications, but just have to adjust the levels to help protect the kidney as well. Because when you're first out of transplant, obviously your immunosuppression is higher, and then we can lower it eventually back down to where I am. So the team of kidney transplant and dialysis doctor and my cardiologist and my lung transplant doctor have all really the last year have been just emailing back and forth in the portal with each other regarding the challenges that I've had. And it is very reassuring to know that everybody is in communication. But I have to say the lead of that team has been my lung transplant doctor, Dr. Han, and she has stayed the primary on my case.
Wonderful. Thank you for that. And thank you for reminding us of the importance of having a good team supports around you, and that it really does take a village. So thank you again.
Thank you.
Wonderful. Appreciate it. All right. Next up, we're going to watch a brief video thanking our frontline workers, and then we'll move to the next part of our agenda.
My name is Nathalie Spicer. I'm a patient advocate at one of the major hospitals here in the city of Detroit. I've done better than I expected to do. We continue to wear our PPEs, making sure that our hands are washed, making sure that others that we work around are doing the same, and reminding others that we must continue to stay safe.
Hello, my name is Randy Bahura, operating partner manager with Fuddruckers, Southfield, Michigan. This pandemic has affected not just me, not just the restaurant, but all my employees and close family and friends. We've made a lot of different changes to cope with the COVID-19 restrictions. It's been hard on everybody, financially, mentally. Hopefully this will be done over with soon. Can't wait to get my vaccine. We all have signed up for the vaccine, just our turn hasn't come yet.
Hello, my name is Valicia Thomas, and I work for Detroit Public Schools Community District, and I am an English master teacher. In person, my classroom is known to be a safe, secure, and structured learning environment, and even I am lost without providing that for my students at this time. I am inspired every day to keep going because I know that my students need me.
Hello, my name is Rita Jordan. I'm a licensed and certified pre-planning consultant and director of advanced planning for OH Pi III Funeral Home. Unfortunately, we were not able to meet with families in person, and that was dramatic, not only for the family, but for us as well. We are so accustomed to hugging our families and providing comfort with them and sharing this journey with them. So for us, it was difficult not to be able to see people in person and to assist them. I will be extremely grateful when COVID is over and we can go back to basics and continue to give hugs and support and love and comfort to our families.
My name is Rena Oddish. I am a pulmonary and critical care physician at Henry Ford Hospital and the medical director of care experience for the health system.
My name is Judith Gray Davis. I'm a healthcare worker at the Henry Ford Health System in the ICU.
I'm here today because I nominated Judy as a healthcare hero based on the work that she did for our patients during COVID.
You know, because I'm just passionate about what I do, so my patients always came first.
We had patients who knew that they were not going to come off the ventilator if they went on.
I don't want to go on the ventilator because I'm gonna die. So I was trying to reassure him. I said, no, you're not. He said, yes, I already know if I go on this ventilator, I'm not coming off. So I need to call my wife and I need to explain to her. And just in the room at that moment with the doctor and the nurses, looking at him, trying to explain to his wife where insurance policy was, how to pay bills, what are the PIN numbers to this account.
To let those men leave feeling like they had cared for their family, alleviating that burden.
Not being able to just touch and hold them the way they needed to be held because they couldn't have visitors.
She served as surrogate family for patients who couldn't have loved ones at their bedside. She talked people through their most difficult moment.
Wonderful. Next up on our agenda, we're going to hear a great presentation from Will Sherry. Will is a licensed medical social worker, as well as the director of Spectrum Center here at the University of Michigan. And Will is going to talk to us about LGBTQ plus identities and inclusive practices. Will, good morning.
Hi, good morning. Thank you so much for having me. Just a quick technical piece. I think I just lost the, there we go, the screen. So just want to start off by saying that I'm honored to be a part of this symposium. It's not something that I've been a part of before. And just listening so far this morning and knowing yesterday's agenda, I feel really honored to have heard the introductions, the welcome, and particularly to have heard Jennifer's sharing earlier. I imagine a 3-year-old does keep you really busy. And I think you really kind of set up unintentionally some of the things that I want to touch on today by just sharing, like, families really do look all different. And part of being cared for is being seen. And I think that you really demonstrated what that means in your story. So thank you. And really appreciate the welcome as well around just the importance of health equity and the work that Michigan medicine and wider health communities are doing. So I'm gonna share briefly just a little bit about the Spectrum Center. So I am the director of the Spectrum Center. The Spectrum Center is our gender and sexuality center at the University of Michigan. This center was co-founded by Jim Toy, who's still an active member of the Michigan community, and Cynthia Gare in 1971. So as a college sexuality center, when we opened 50 years ago, this is our 50th anniversary year. When we opened, we were the very first center of our kind in the nation. So we're really excited to celebrate 50 years this year. We'll be kicking off a set of 50th anniversary programs starting in June. So just to give a sense of the center, we have 6 full-time staff, and like many of you, we work with graduate students and undergraduate students and volunteers in kind of setting up who am I in this context. Really, our center focuses on the student experience, but what that means is that we work at a really big organization like a university that impacts students through a lot of systems, through a lot of communities, and through a lot of interpersonal interactions. So that has us working in things like architecture, what do spaces look like? What do bathrooms and locker rooms look like? Housing, HR policies. We certainly have great partners in OHE and our Office of Health, Equity, and Inclusion. And so we are not, experts in a medical field, but what I'm going to do in my 20 minutes is try to kind of focus on what are the foundations of inclusive practice that really set the stage for some deeper learning. So I'm going to start with just some fundamental concepts that we work around. So when you hear me use certain language, it makes sense, and we've kind of set that up. So we often use the terms queer, LGBT, and LGBTQ to reference an entire community. It's important to know not everyone is represented in these terms. Some terms that people use are really culturally specific, speak to particular subsets of community, and some of these terms don't resonate with people. Certainly the term queer has a long history and a continued use as a slur in many spaces. We see many people that feel uncomfortable with the use of that term and wouldn't use the term to describe themselves. And then I mentioned I work in a student-driven center. A lot of students really resonate with the term queer. They feel like that term really represents who they are and helps people to understand more about them. And we're going to talk more about terms and terminology. But I think one of the important things to know is that, you know, this work is not about memorizing terms or being able to define everything. It is about investing in our own self-knowledge, but it isn't about being able to just regurgitate a set of terms without understanding how those terms exist in a context. And that actually my best work is just really listening to individuals and asking questions that are important for me to understand in doing my work with them. So we're going to make some just like distinctions around some terms that we utilize a lot in the center. So sex assigned at birth is really what we utilize, and you're probably maybe familiar with that when a baby, you know, before a baby is born. I have 4 kids, so I definitely know that, you know, these are conversations that we're having early on. I know many of us have probably seen things like gender reveals, and this is where we start to kind of differentiate. That when a baby is born, there is a sex assigned at birth that goes on a birth certificate. That is different than one's gender. One's gender is really constructed, right, out of a sense of self over time, can be very young, can be something that someone comes to and understands at any point in time. For me, I really did not understand that my sex assigned at birth was different from my gender until I was in graduate school. I didn't really understand those concepts as different. And that really limited my ability to understand myself. It's really critical to see the differentiation of what someone is assigned based on their body, and bodies hugely differ, right? And how someone understands themselves and who they are. Our gender expression is hugely social and hugely cultural. I know I'm not from the Midwest. I'm from the East Coast. I'm from New York, and my wife is from the Midwest. And we talk a lot about how gender is read differently in different spaces, right? What one person might consider as masculine, another might not. That these things are really cultural, yet there are still norms, right? There are privileged ways of acting and behaving in different contexts and cultures and organizations and spaces. So gender expression, you know, might be how we express our gender, but for many people, there might be an expression that is not their true sense of self, right? Because of bias, because of harassment, discrimination, the potential to lose one's life, which we know exponentially impacts communities of color when we're talking about trans and non-binary people. And then we talk about attractionality. This is really synonymous with sexuality and sexual orientation. In the Spectrum Center, we really appreciate the term attractionality because it is broad, right? Sexual orientation really has us kind of hone in on a behavior that may or may not fuel how someone identifies. I think in this work, something I've definitely learned is that people have lots of different behaviors, right? That may or may not align with how they identify. And so attractionality is really much broader. It recognizes a person's emotional, physical, and sexual attractions or not to others. And so we appreciate the broadness of that term, because when we see something in a limited framework, that sets up our interactions with patients, with, in my case, students or others, only in that limited way. And then my questions to understand you are only through a very limited framework instead of something broader like attractionality. With regard to specific terminology, just kind of having some foundational concepts around some terms that I've already used. So we look at gender identity and really think about how people can identify in lots of different ways, right? And so when we think about survey questions or demographics, that's one way to think about sort of how we understand people's gender. And so what we always kind of recommend with regard to collecting gender is that yes, there are people who are cisgender. Their gender identity aligns with the gender they were assigned at birth. And there are people that are transgender. My gender identity does not align with the sex I was assigned at birth. But there are men who are cisgender and men who are transgender. So when we look at collecting gender, we like to say, asking people, do you identify, are you a man? Are you a woman? Or are you non-binary? Someone whose gender identity is not exclusively man or woman. And we like to ask that question separate from, are you transgender? Because I am a man, I got there differently. I am not a cisgender man. But if you place kind of trans man separate from being a man, sometimes what we're saying is you are a different kind of man. You are not a normal man. You are not a traditional man. And the importance of sort of recognizing people for who they are and asking the questions that can really get to what we need to know about people to do our work and care for them well. And then to Dr. Newman's introduction about some of the structural things that really impact patients, staff, all of us, are things like sexism and homophobia and transphobia. These structural isms, right, that kind of feed our organizations, that it sounds like Michigan Medicine is doing a lot of work, a lot of anti-racism work to identify how do preconceived notions about people impact the healthcare access and inequity that we see. And that's certainly true for data that we have on LGBT people. We know a lot about health inequities. And I really wanted to focus today on like what we can do as individuals and sort of an honest look at allyhood. We do a lot of allyhood work through the Spectrum Center. Sometimes it's called accomplice work. How do we be there for one another in ways that really matter and make an impact? So I think it's really important to dive deep into your fields around health inequity data. That's not my specialty, but I think that that's incredibly important. That like self-knowledge, allyhood requires deep and often uncomfortable self-reflection, that there is no shortcut to this work. There is no 20-minute presentation. There is no day-long institute. Those are all pieces along our journey. That we need to understand our motivation to engage in LGBT allyhood work and the impact of our words and actions. That, if our motivation is really to make a difference in our spaces, knowing that that is a long-term journey and one that will come with a lot of feedback that can be hard to hear, right? But our willingness to be open to that. When we use a wrong pronoun, being open to that critique of what that meant for someone, or being corrected in a space. It isn't always easy. And that work, because often it wasn't our intention. And so that work really starts with sort of us knowing that our intentions, right, are important to us, but don't need to be kind of the center of our interactions with others, that we can be deeply invested in just the learning. And that this self-reflection around this work can often start with asking ourselves questions like, how do I experience and interact with gender? How do I express my gender? What does being my own gender mean? So I think oftentimes what I see in LGBT work is a desire to understand communities from sort of understanding the language, doing reading, understanding the other in a way. And I think that my push is actually we all interact with gender. We all interact with attractionality. These aren't just concepts that exist within a queer community. And so I think my push for us as a collective community is to really think, what is my lived experience around these concepts? Because within that work, we are able to care for others who might be having a more marginalized experience. But just to understand the marginalized experience without understanding my own, which may or may not exist in being marginalized, will limit our ability to be allies in this work. And then want to kind of close up with some inclusive practices. Pronouns is always something that we're asked about. He, him, and his, she, her, and hers, they, them, and theirs. These are some examples of how people expect others to refer to them. You might hear preferred pronouns. We lean towards just saying pronouns. A preference is something, that it's great if you do it, but like if not, that's fine. And pronouns are really an expectation. Like I expect to be referred to based on how I identify in the spaces that I'm in. That misgendering happens. It's something that happens, I think, for all of us. And really being able to navigate that situation, we recommend, apologizing, I'm sorry, and correcting myself, but not kind of sitting in or explaining like, oh, well, I've just known you for so long as this. And so it's so hard. Like, I think, that's maybe our internal voice, but when it becomes external, what we're doing is sort of explaining why I couldn't commit to making this a priority. And that's really what it takes, is active work. And that can be hard when we're doing active work around a lot of different things. But it is a commitment that is necessary in our own growth and learning. I've included some websites that can help us practice pronouns, not on people, but online, which can be really helpful. I also recommend like putting pronouns in your Zoom name when you log into meetings, starting things with pronouns. I put mine on my slide, but I use he, him, and his pronouns. There are lots of ways, but it takes commitment and dedication to change. And then lastly, inclusive language. And so some recommendations that we make around using more gender neutral language when we're referring to individuals and groups. I think as people, we're really used to making assumptions all the time based on how people express, based on what they look like, based on what their voice sounds like. Based on a lot of different cues we have, and that's natural. And it does take work to question and reflect and identify those biases, and to for ourselves, and then to put into action new habits, right? Not gendering people if I don't know. Asking pronouns can be uncomfortable at first, but the more you do it, the easier it gets. Understanding nuances in terms is really important, but what that often takes is us asking questions and explaining the why. I'm a huge proponent in healthcare settings of helping people understand why we're asking the questions we're asking, because that also helps us to ask ourselves why we might need to know. So it might be like, I want to know more about your family and your support system and what that looks like, so I can help you to develop the support you need to work and navigate these health challenges. Versus, are you married? Right? Do you have a husband that's supporting you? Those kinds of closed-ended questions. And that we work, that there's what, hundreds of people on this call. We are all entering this work from different places. And if we are someone that has a lot of knowledge, offering that knowledge to others when we can, and not freezing people who might have made mistakes and assuming that they're never going to get it, or they're never going to be active ally in this work, that I think we all are on a learning journey. That there's some things that I know a lot about and other things that I know less about, but that's on me to identify my gaps and commit to doing more and better. And so that's really, I think, my ask of all of us is to be able to invest ourselves in the work that we need to do, even when it challenges other aspects of ourselves. Other pieces of our identity, to making a priority the importance of LGBT people and identities in our work. So I really appreciate being here, and I'm happy to briefly, as time allows, answer any questions.
Well, thank you so much for fascinating, informative presentation. First, I just say congratulations to you and to Spectrum Center for 50 years of great work, really forward-thinking work. And as a provider, just reminding us that if we want individuals to have, both great healthcare, but also a great healthcare experience, that it requires active work and us being willing to continuously learn and actually be very thoughtful about our communication. We have a couple of questions, and you actually touched on some of the intersection issues. The first question for you was, how are inequalities similar or different in the LGBTQ plus communities of color?
Yeah, so I was able to pull up both of these. So this is really helpful. I think, as was described in the welcome, that at the intersection of multiply marginalized identities, right, we see the continued lack of access to healthcare. And lack of access to information, to quality, culturally affirming care. Some of the ways this shows up on our campus is even looking at the access to individuals who have been trained and have knowledge at those intersections. So we have an amazing team at our University Health Services, at our counseling center, and a lot of the work that people are doing still has gaps at the intersections of multiple marginalities. That, like, there are not as many people who can really speak to the needs of queer students of color. And recently, students did put out a set of demands that speak to some health access issues that they would like to see addressed. So we are seeing people really speak to, I'm not finding the care that I need. I'm not, the waiting time might be longer. Maybe we're doing more external referrals. We also do have some amazing organizations on and off campus for well-being care in general. But I mean, we see tragedy on a national and international scale around the murdering of trans women of color. I mean, there is so much data and information that points to this crisis in our nation and in our world that I think Dr. Newman really spoke to at the intersection of racial inequity. The other question that came was on some common barriers. And so I spoke to a few. I think access, I think navigating really complex and large systems is really hard, like a hospital, like a university, that we can be collecting some great info and not sharing it, that, you know, people can feel like they have shared over and over and that information doesn't get anywhere, that access to healthy and safe relationship information is really critical to our students, to mental health counseling, and just navigating physical and social transitions on a really large campus that has a lot of resources, but sometimes, and hospital systems, sometimes all those resources mean it can be confusing. And investing in that resource navigation, because those barriers are real and can turn people away. So I think those are some of the things that come to mind.
Fantastic, fantastic. Thank you. And also thank you for your discussion about thinking about how to be a good ally. I think was both informative and also builds on the discussion yesterday from Dr. Sananday, which was being an ally in the context of race. And so I think very, very important, very informative. Well, thank you again. I think we learned a lot and we appreciate you taking time to join us today.
Yeah, thank you all so much.
Appreciate it. All right, great, we're doing great. So next up, we are going to have a talk by Dr. Shakir Hussein. Dr. Hussein is a transplant surgeon at the Detroit Medical Center. And Dr. Hussein is going to talk to us about social justice and access to transplantation. Dr. Hussein.
Good morning, can you hear me?
We can.
Okay. Good morning, everyone. Thank you for giving me the opportunity to be here today and to speak with you. And I would like to see my, okay, good. Do I have the control over the slides or should I just say next?
You should have control over them, but if that's not working, let me know.
Okay. No, I don't see that. Yeah, okay, good. Okay, now we have the control. Thank you. My name is Shakir Hussein. I'm a transplant surgeon by training. I work currently at Detroit Medical Center. I have no disclosure except English language is not my first language. My slides are messy and they're long. So good luck following me in this presentation. Okay. Next. Oh. So when I was asked to present for this year, the topic that hit my head first and the most is there are a lot of interventions that were done in the past. The question is how effective, efficient, and how much do they move the needle in the right direction? No one said it better than Reverend Martin Luther King Jr. when he said, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. Next. Can you guys hear me?
We can hear you. We're on the legal definition of minority.
Yes, but my slides, they don't move. Can you move the slide, please? Here, I don't know what's going on in my computer. Okay, good. So the one before, previous one. Okay, so I looked to see what is the legal definition of a minority in the United States, and apparently there is a legal definition. It's mostly ethnic, as you can see here. Then I found another interesting concept in the legal system when it comes to employment. Next slide, please. Next slide, please.
Maybe it's taking a little bit longer to see it on your computer. We're at disparate impact.
Okay, because I can't see it in my computer.
Can you pull up your slides so you can see them, and I will follow along as you identify the right slide?
Okay. Yeah, disparate impact. This is an interesting concept that says disparate impact occurs when policies, practices, rules, or other systems that appear to be neutral result in a disproportionate impact on protected group. In other words, you have a fair rule that is applied fairly with an unbalanced outcome. And that's a very interesting way of thinking about things, because what sometimes we think is, if we apply everything fairly, the outcome should be also fair. So let me try. Next slide, please.
We're at protected groups.
Okay, I'm trying to get my own slide. Protected groups, also this is a legal definition of what are groups that are protected. And I think the legal history in the United States in the last 50 years or over started realizing that there are certain groups based on gender, background, color of skin, and gender, and sexual orientation and disability, that they will be disadvantaged even with a fair and balanced system. So let me see if, yeah. Okay, next slide. I can't see anything here in the monitor, so you have to tell me what slide is up.
Racial disparities in patient selection for liver transplantation, an ongoing challenge. It's an article.
Okay, so this is I'm really sorry. You know, I got to the best computer in the department, 4 monitors, and it is just frozen down right now. I can't move anything. I don't know why.
We'll make it work. That's all right.
Okay. So this slide is just a thank you slide to our colleagues at Henry Ford who published this paper in 2019 that showed Black race, people of Black origin, even after adjusting of all other factors, they still have 26% lower odds to be listed. Forget about getting transplanted, just to get to the list. And that says a lot. Okay, next slide.
2-year analysis shows effects of kidney allocation system.
Sorry, which one is that?
2-year analysis shows effects of kidney allocation system.
Oh, but that's, I can't pull them here. Hold on one second.
It's a news release from OPTN.
I'm sorry. I mean, I didn't anticipate this problem. This is one problem I did not anticipate.
No
worries, I'm trying to put them in front of me right now.
No worries.
Just give me a second. Okay. Let's see when this one comes up.
Dr. Hussein, it does show me that you now have control of the screen if you want to.
The problem is it froze. I can't move anything.
Okay. Yes, it froze too. Dr. Norman, it looks like we may have lost Dr. Hussein.
Okay. All right. Did we want to try to move forward with the panel and then circle back?
That sounds
I don't think that Dr. Brown is on right now.
Let me take a look. No, he's not on. I don't see him. All right. Well, why don't we do this? I wonder if we could touch on, I know we have Mr. Valbuena on. I wonder if we could, it might be useful to talk about CHAS a little bit and just give people some more detail about that, that center, that program, without putting them on the spot too much.
Sure, no worries. Good morning, everyone. I'm Felix Valbuena. I'm a family physician, and I serve as the CEO of the Community Health and Social Services Center, more commonly known as the CHAS Center. I'll give an abridged version, and then you can let me know when I should stop. So CHAS is a federally qualified health center. We're in our 51st year of service to the community, and we are the go-to resource for everything health and wellness.
Hello? Can you guys hear me now?
Yeah.
Hello? Yes, we can. Yes, we can hear you, Dr. Hussein.
Okay.
Okay, sorry for the problem. What I'm going to do is I put my slides on the side and I'm calling with the phone.
That will work. I will pull your slides back up here.
Okay, so, and then I will tell you. So the slides.
So we're on the OPTN press release about 2-year analysis shows effects of kidney allocation system.
Yes. So this is one of the interventions that I would like to talk about. A few years ago, UNOS introduced a new kidney allocation system. The implementation started in December of 2014, and the result came out in 2017, July 2017. One of the things that the results showed are kidney transplant percentages by recipient ethnicity are now more similar to the ethnic makeup of the waiting list candidates. So it is not similar to the ethnic makeup of the dialysis population, it is the wait list candidates, which means if there is discrepancy, then we are still behind. So let's look at the wait list candidates as of February of 2021, and it showed for Black or African American 31.9, almost 32% of waitlist candidates for kidney transplant are Black or African American. Does that match the dialysis population? Almost, but not there. African American constitute 35% of all patients in the US. National Institute of Health has the same percentage, 35%, like the National Kidney Foundation. So let's look a little bit at the kidney transplant by ethnicity. And I picked 5 years for this presentation, 2005, 10, 13, 17, and 19. 13 is before they implemented the new kidney allocation system, 17 after, and 19 is the last year before the pandemic. And when we look at Black or African American, we will find that actually the percentages went down. Maybe the numbers are up, but they are either similar or down. And this is for the United States, living donor and deceased donor. Look at Michigan. We are a little bit better than the rest of the United States, but looking at the fact that around 40% of dialysis patients in the state of Michigan are Black or African American, our transplantation rates at 2019 were not that representative, or around 5 to 6 points lower. This is deceased donor by donor ethnicity. This slide is about the donors, not the recipients. And as we can see, in the state of Michigan, it's around 18%, almost consistently are Black or African American, while 14% are Black or African American as a constituent of the state. So African Americans and Black, they contribute more than their percentage in terms of deceased donor to the donor pool. Same thing for in the United States. It averages 15 to 16%, while the percentage of African American in the United States is 13%. So the concept that African American, they do not donate deceased donor is a misconception that we hear every now and then. So regarding the living donor, this is a slide that shows cause of death or mechanism of death. And I picked few items to show the difference and the community perception. You find suicide and drug use is significantly more in white population than Black population, while homicide and gun violence is more in the Black population. The thing to be noticed is there is a significant rise in the drug deaths in the United States on both sides. African American, the living donor in African American is less than Caucasian. And according to this report in the National Kidney Foundation, Dr. Segef is a nationally known kidney transplant surgeon. And he explained that by the epidemic of obesity, hypertension, and diabetes in many African Americans. Another paper published in Progress in Transplantation showed that there is a general lack of knowledge of how to do the donor process, or there is a gap between the programs and patients when it comes to Blacks and African Americans. And there is gap in the learning, the knowledge, the concerns, and the expectations of support and communication. Now, this is a brief thing about the kidney allocation system that was implemented in 2014. There was another regulatory items that were implemented in 2006 by a gentleman. His name is Thomas Hamilton III. A lot of the transplant surgeons who practice in the United States know this name. And for a while, he was on top of survey and regulation, and he introduced some quality metrics that led to what we believe decrease in volume or stagnation in volume, and draconian punishment for programs that did not match his quality parameters. He published a couple of papers in PubMed. One of them is clearly saying that programs that didn't match Medicare standards, they had to go down on volume. And another paper that said mitigating factors came from those programs to explain their lower outcomes were not satisfactory. And during his tenure, between 25 to 30 programs closed. If you look at this, this is from Yunus, you'll find between 2006 through 2015, there was relatively stagnation of deceased donor transplant in the United States that changed starting 2017, 18, 19, and by 2020, we had over 17,000 deceased donors. Was that the effect of the Medicare? I don't know, I can't prove that, but that is a common theme among a lot of the transplant programs, blaming those quality measures or draconian punishment for the quality measures on stagnation of the volume. Now, let's look at the percentages of listing. And that is about probably the most important concept to look at. If the percentage of African American on dialysis in the United States is around 35%, then the percentage of listing in the wait list should be, more or less around that percentage. But it's consistently in the United States lower. It's in the 27 to 29%, which is 6 to 7 points lower. In the state of Michigan, around 39 to 40% of dialysis patients are African American. The listing is 31 to 37%. In addition, the kidney allocation system didn't improve the percentage of listing as we can see it here. So who is the gatekeeper of listing? And what is the first thing that we do as transplant community to improve the quality? The first thing is to institute contraindication for transplantation. To say, which patients are not going to do well. We know those, so we shouldn't even put them on the list. And this is from University of North Carolina. Give you an example: malignancy, cancers, lack of family support, having a lot of heart disease, coronary artery disease, stroke. This is from Johns Hopkins. Shows the same things, including or adding to it obesity, age, social support. Now, the question is, in my mind, is there any single factor, one pathology that can explain all those contraindications or be a significant risk factor for those contraindications? So let's see, I did some research and let's see what we found. Okay, this is from the International Journal for Equity in Health. And they are talking about social capital, which is how many people they know you, how good of a relationship they have, how much exchange of benefits they will be willing to you. And in the transplant community, social support is very important, especially in lung, heart, liver transplant, things that will make you quite debilitated after the transplant. So the findings showed that there's a strong evidence to suggest that people with lower socioeconomic status generally have lower levels of social capital. In other words, if you don't have money, you probably don't have a lot of social capital. This is next slide. Are you guys following me?
I am following you, yes.
Yep.
Okay. Okay. So this is from the Washington Post and can clearly show that the more money you have, the more friends you will have. Less neighbors, less relatives, but definitely more friends. So you have money, you have social support. Next slide. This is from the Journal of the American Heart Association. It shows that income is associated with medication adherence and mortality in heart disease. And we know that people with significant heart disease, they have a chance not to be transplantation candidates. So also income will affect that. Next slide. Now, this is another slide that shows stress and poverty are more of a predictors in treatment adherence to HIV, which is a fatal disease. Again, same theme. No money, no adherence, no compliance. Financial strain is associated with medication non-adherence. No money, no adherence. Next, I think you guys are getting the picture now. So the National Cancer Institute, people in low and middle income counties in the United States are more likely to die of cancer than those who live in high income counties. We know cancer is one of the contraindications to transplantation if it's not treated well or it's spreading. This is from JAMA Psychiatry. Low level of household income are associated with several lifetime mental disorders and suicide attempts. Again, Low money, more psychiatric illness, and uncontrolled psychiatric illness is a contraindication to transplantation. Next slide. It shows that neighborhood socioeconomic status projects how people recover from stroke, and debilitation is one of the contraindications, and frailty to transplantation. Interestingly, I found this slide from Morocco, not the United States, which showed individuals from the most deprived urban households bear a higher risk of stroke. Next slide. So, next slide, grandparents' wealth and body mass index. This study found that when the grandparents of the child are wealthier, it's less likely the child will have a high BMI. And we know significantly high BMI can be also an impediment to transplantation. This slide shows that people who have more income are more likely to have insurance. People who don't have insurance, they don't get transplant. From the next slide is from the Kaiser Family Foundation. It showed that families with low incomes are more likely to be uninsured. If you are uninsured, you ain't getting a transplant. The interesting thing about this article is from China, and it's studying the role of wealth and health in insurance choice. But what made me interested in the article, it is published in Mathematical Problems in Engineering. For whatever reason it is, the article couldn't make its way to any medical journal. It ended up in a mathematical journal. I have no idea, but it doesn't seem, you know, it's taken seriously enough to be discussed in medical journals. It showed the same thing. People who have low income are less likely to have medical insurance. Now let's look at one more slide, next slide, that shows the chances that people will defer their medical care due to cost. And I think it is very simple or it's very straightforward to assume that if you don't have money, you will defer. And as we can see, the poorest in the first quintile, they are more likely to defer medical care up to 25% early on, and the gap is increasing. This slide was published in 2012, and it showed that the poorer the person is, the more likely by significant margin to delay their care. This slide shows that with the affordability gap between earnings and premiums are getting bigger and bigger and bigger. This slide shows what percentage of people who received transplants between 2008 and 2015 have private insurance. And as you can see, Blacks and Hispanics, they have the lowest percentage of private insurance among all the categories. Next slide. This is from Peter G. Peterson Foundation. In the last 90 years, you can see clearly African American and Hispanic, followed by Hispanic, they have the lowest income. This one since 1967, and consistently, African American, they have the lowest income. Next slide, same thing. This is from Pew Research, I believe, from Hamilton Brookings Institution. This one from the Pew Research Center. Next slide. And it shows that the median income for an African American family, for a white family, is 13 times that of an African American family. And that's we're talking about 2013, which is almost 8 years ago. Now, this slide shows the gap of household wealth increases with age, and it's around 11 times at the age of 60. And we know 60% of people on dialysis are 60 years and older. So by the time a person ends up on dialysis, they won't have the money to take care of themselves. This slide shows, the next slide shows the difference is home ownership, same pattern. The slides and unemployment. Blacks are 2 to 3 times white and Asian in terms of unemployment. Now, this is an interesting slide, shows that in terms of college degrees, Caucasians are 50% more than Blacks or African American in terms of obtaining a college degree. Now, the next one will show that when you hit a postgraduate degree, there is a significant discrepancy in the income by race for everybody who has a degree over bachelor degree. So the more you study, the more degrees you get as a Black or African American, the bigger the gap will be in income. The same slide is just in a different way, and it can clearly show that with more degrees, there is a bigger income gap. What does that mean? That means that Black families are gonna have more student debt. So the more you get degrees, the more you get into debt rather than the more you get yourself out. The next slide shows what are the explanation of the racial income gap. So the orange color indicates what they considered initial causes of wealth gap. And what they mean by that is things that happened during the segregation time when African American and people of African origin, they did not have access to school, to small businesses, to loans. And these things started changing. However, what did not change, what also changed is the unequal labor income. So in 2007, the initial causes of wealth gap were very small, but the unequal labor income was so high that the gap continues to be the same, as we saw in the previous slide. Now, this is one other slide that shows over 50% of Black or African American kids, they live in a single parent home. And why is that? One of the factors that can be talked about is the parents who have criminal records, they have hard time, parenting their children. So I looked at a couple of crimes that are maybe common or we see, or violations that, they are not that big in terms of their moral part, but they are, breaking the law. Next slide. So drive under influence, driving your car when you are drunk. So who does that more? Based on this paper that was published in 2005, self-reported rates of driving under influence were highest among white men. Now let's see what that results. This is from a private law website. That is why I took the name. But in certain states like Connecticut, the dismissal rate of driving under influence is as high as 50 to 70%. In other words, driving under influence, which can result in fatal car accident, are dismissed to a significant degree. Now let's look at marijuana possession. Now there are changes, but the impact has been around for decades. In 2010, according to the ACLU, 52% of all drug arrests were as a result of marijuana possession. And Blacks are 3.73 times more likely than whites to be arrested for marijuana, despite roughly equal usage rates. Till today, the federal laws make possession of marijuana is a crime, and even small amount can result in jail. Now, in New York, there is something called, smoking marijuana in public view. And when they looked back to see, they found that Black and Hispanic arrests have been more likely to be detained prior to arraignment, convicted, and sentenced to jail than their white counterparts. So what does that result in? People with criminal record are more likely to be unemployed, but there is a significant gap between 4.3 and 6.8, where for white men it's 4.3 more times not to be unemployed. At the same time, 6.8 for Black women. In other words, being a Black woman, having a criminal record is really devastating. And we can see here clearly that reporting first time of opioid use is much higher in white population than non-white. And if you look at the criminal part of it, you can tell, you know, if someone ends up in jail and the other ends up in rehab, the one who ends up in rehab is more likely to report their opioid use. This is a picture from the 1970s to see the stereotypes, IV drug epidemic in the 1970s. It shows the typical way the society looked at people: poor African American, Vietnam veterans, and Elton John, a gay man. Now let's look at the transplant survival. Let's see, did these results in change in transplant survival? I mean, we can assume that those draconian quality measures improved the overall survival, decreased the access to transplant. But what did it do to the survival for African American after transplant, the ones who had to jump all these hoops in spite of poverty to get a transplant? And the interesting thing is that I found, this is numerical, not statistically significant, but numerically for pancreas, lung, and intestine, African American, they had the highest numerical survival. Liver, kidney, pancreas, and heart, the lowest survival. I have no explanation to that. It's not statistically significant, but it's an observation. Now let's move a little bit from kidney transplant and look at lung transplant. So in the world of lung transplant, in 2019, there were 20 states that had zero lung transplant. They have no transplant programs, lung transplant programs. There are 11 states that combined did 227. Compared to the city of Philadelphia, they did less because Philadelphia did 230. So the city of Philadelphia did more lung transplants than 31 states. So let's look, next slide, let's look at the population. The 31 states, they are combined 96 million human beings. The greater Philadelphia, 7.2. So 7.2 million had more lung transplants than 96 million in their area. So let's look at it. So this shows maybe those states, I said, you know, maybe those states, they don't donate lung. That's why they don't get lung transplants. The reality is that 20 states that had zero lung transplants donated 284 lungs. And the 11 states that had 227 transplants donated 505 lungs. So in other words, 31 states with combined 8.4% of all lung transplants in the United States contributed 28.6% of all the lung donors. Huge discrepancy between how many donors they gave and how many transplants they done. So I looked again and I said, you know, maybe Philadelphia metropolitan is 7.2, but it is, you know, servicing more larger population. Here is the driving direction from Google. Within 5 hours of driving from the inner city of Philadelphia, you can get to more than 10 lung transplant programs. Boston is 5 hours, 15 minutes. But other than that, you can see the picture. So why did I choose lung transplant? The reason is I remember a story that happened in 2013. Next slide. This is a story of a 10-year-old who needed lung transplant. She's on the left side of the picture. And this is USA Today, so I'm not violating HIPAA. It's USA Today violating HIPAA. She needed a lung transplant. At that time, kids less than 12 years old were not, they were not allocated lungs that are coming from donors who are older than 12 years old, for whatever medical reason it is. But there is a judge in Philadelphia who decided that rule is not fair enough, let's change the rule. And the kid received the lung transplant. A few weeks later, the kid needed another lung transplant. So double lung transplant twice to save the life of a child. Now, the life of this child is very precious. The question is it the judge's place to make that decision? And is it fair, appropriate? or equitable, that 4 single lungs or 2 double lungs to be assigned to one person, while other people are not getting lungs. Now, let's look at another thing that is related to why rules can be changed by legislators or judges. This slide from the econofact.org that showed that in the 2016 election, the percentage of people voting divided by income is much higher at the high income level compared to the low income level. In other words, it's more likely for your voice to be heard if you have at higher income or educational level. This is published in the Central European Economic Journal, the gross domestic product per capita in logs and health indicators. The health indicators here are the World Health Organization indicators. So they rank people, you know, you score high or low. And you can see there is a linear relationship between the income per capita and the health indicators. This is, the next slide is a little bit even more realistic because it's not health indicators, it's just, you know, life expectancy. And you can see clearly that the more income per capita it is, the more likely people live longer. However, what is interesting about this slide is people who hit $7,000 or $8,000 per capita per year, they will have the same life as the one who had 30, 40, 50, or 60, more or less. So it really doesn't take a lot to get people to have a higher life expectancy in terms of income. To sum what I have been, trying to present, and this is from the Harvard Gazette. It is simple in one sentence: money equals quality healthcare equals longer life. It's very simple. Now, what is our role as a medical society in those, I call them injustices in healthcare? So at this point, do not do harm. Don't do harm. Is that enough? And these are some stories from the concentration camps in World War II during the Holocaust time. And this is a doctor who worked and tried to help people in one of the most famous concentration camps. And according to the article that published her story in 2020, Dr. Pearl did not have the luxury of doing no harm. Instead, she worked to save lives and minimize the harm. But isn't that sometimes what we do, where we feel we are tied, our hands are tied behind our back to take care of the most vulnerable, poor people, because the regulations that are placed ahead of us makes it impossible to take care of them. There are many doctors who don't take Medicaid. It's almost impossible to transplant a patient who doesn't have insurance. Self-pay people, they sometimes have a hard time getting a colonoscopy. And interestingly, there is one study published in the Public Health Laboratory, from the Journal of Royal Society of Medicine in England, that saying that 90% of members of the medical profession at the highest level were involved in one way or another in the atrocities of the Holocaust in the concentration camps. How did they reach that level? The question is, 100 years from now, how are we going to be judged by the newer generation when they look at what we are doing? Are we going to be looked at the same way as we are looking at those doctors who participated in the concentration camps? This is an article published in Israel Journal of Health and Public Research. After the investigations, after World War II, the world promised never again to repeat the atrocities of that horrible time. One of the things that they found, how did they justify, whoever, doctors or politicians, is that priority of healthcare of the state goes over the health of the individuals, and it dehumanized those considered unworthy of life. This is a very horrible thing to say. But let's say, what do some of us say today? So I looked, next slide. I looked at one of those encyclopedias and I found this term, non-productive members of the society. Why did I look up this term? Because I heard it from some of our script texts that if he who does not work, neither shall he eat. And I was told, you know, this is in the Bible. So I researched the term, and I found that the communist head figure, Vladimir Lenin, used the same exact phrase during the famines that killed hundreds of thousands, maybe millions, in the early of the 20th century. So in the past, when some people were called unworthy of life, is that equivalent to us today saying non-productive members of the society? So what is next? I think with the evolution of medicine, with the evolution of science, with the evolution of society, with the evolution of the fact that technology reached a point where I'm presenting, looking at a computer. I'm not seeing anyone right now. You guys are not seeing me. You are hearing my voice, looking at my slides, trying to interpret my thick accent. I think public healthcare, population healthcare also evolved, like the society evolved, like technology evolved. And it's no longer enough to take care of, for the medical community, to take care of patients and go home. There are other factors that we know for fact that affect our patient well-being, life, access to care. They are politically charged, but the truth is they do. Universal coverage, unemployment, income and wealth inequality, criminal justice reform, voting rights, and student loans. These things result in life expectancy discrepancy, access to healthcare discrepancy, access to transplant discrepancy. It is impossible to look at the origin of the problem and expect politicians to solve it, while on the other hand, we as doctors, we just on the recipient end of those rules and those circumstances, and we are trying to just do our best. Now, this is the last slide, and this is a question for all the audience. This is my last slide. So some of you, maybe all of you, are familiar with the Saudi journalist who was living in Washington, D.C., working for the Washington Post, went to Turkey for some reason, went to the embassy of the Saudi Arabia and then disappeared. And now the report's coming out that he was murdered there. So YouGov, which is a British financing polling service, marketing service, did a poll in the United States to see what percentage of people they don't believe the innocence of the Saudi government. And 60% said they do not believe the Saudi government is innocent. Now, on the right side of the slide, look at the pictures of Mr. George Floyd, who died last year under the police custody. Let's put it that way. The most recent USA Today poll showed only 36%, which is compared to 60% last summer, believe this is a murder. After seeing the pictures, after seeing the short clip, after hearing about it in the news all the time. At the same time, 60% believe that Mr. Jamal Khashoggi was murdered in Turkey. They haven't seen the guy before. They don't know who he is. There is no video to prove that. There is no tape that we heard. The senators said they heard it. We didn't hear it. So how can we explain this discrepancy? And that is the question that I leave the audience with. Thank you, everyone. And I'm really sorry for taking more than my time and for the technical problems. Can you guys still hear me?
We can. And thank you for,
okay.
Yes, thank you for that great presentation. And thank you for working through, I think we're all working through some Zoom technical challenges over the last year. So we appreciate it. I want to thank you for bringing to light and highlighting for us, one, the serious impact of economics and financial stability, and how that relates to people's ability to access healthcare, helping bring together this intersection and overlap of policies related to the criminal justice system, economics and healthcare, and pointing out for us this morning the direct impact of these structural barriers that we have in transplantation on the basis of some of our own rules and expectations for stable housing and support, transportation, those kind of things. I wonder if you could just briefly comment on what activities at the DMC at Harper that you're doing to try to help overcome some of these barriers.
You know, I have to say the answer to this question is very difficult, because it is not that there are no activities. It is that from my presentation or my research, I came to the belief that these activities will help some individuals. Outreach to the community, taking care of patients who have no insurance. And you can see a couple of patients here and there, but they are still having a lot of struggle. So I don't think I can say what I can say about this. Whatever it is implemented, it is not making significant difference on population health. It is making difference on some individual people who can get to this. When I was doing kidney transplant here, we transplanted some people. We jumped a lot of hoops, but also at the same time, there are a lot of people who couldn't get to transplant because of poverty, because of have no social support, because they don't have transportation, because they have hard time keeping their Medicaid insurance. So that is how I look at it, more than, you know, this intervention, that intervention. I think I truly believe that those interventions, they are making differences on the individual level, but not on the population health level. I don't know if I explained, I am sure I did not answer your question, but I hope I explained myself well and why I answered it this way.
No, that's perfect. That's perfect. And I think highlights for us the amount of work we still have yet to do. And hopefully this conference is one part of it. Thank you again. All right. We are going to move now. Thank you. We're going to move now to our panel discussion. Our panel this morning is going to be led by Dr. David Brown. In addition to being an otolaryngologist, Dr. Brown is also the Associate Vice President and Associate Dean for Health Equity and Inclusion at the University of Michigan Medical School. And he and the panel are going to discuss, are you providing equitable healthcare with passion and humility? David.
Thank you very much for that welcome, Dr. Norman. And is it good morning still to everyone? I want to welcome everyone to our panel. First, I'd like to introduce our panelists who are going to be working with us today. And the first person is Miss Nathalie Davis, who's worked in human resources for approximately 25 years. Has a bachelor's degree in psychology from the University of Illinois, Urbana-Champaign, and an MBA from the Keller Graduate School of Management, and is currently working on her PhD in business psychology from the Chicago School of Professional Psychology. She is the Chief People and Culture Officer at Gift of Life, Michigan, and is learning the nuances of HR and growing understanding some of the complicated topics thereof. Our next person I'd like to introduce is Ms. Andrea Fleischfresser, is the founder and global multicultural executive and leadership coach, founder of the global multicultural executive and leadership coach at Destination U Coaching and Development. She has 20 years of experience living abroad and more than 10 years in HR. She's an executive coach and completed her certified executive coaching leadership with co-active training. The next person I would like to introduce is Ms. Anjanette Davenport Hatter, who is the founder and CEO of Harambee Care. where she helps social workers live their best lives. She's also the founding executive director of Your Good Village Collective, a nonprofit organization that seeks to improve population health through equitable community-based education and support services. She has a passion for addressing health inequities that led to her partnership in the Community Innovation Program for the MIT, where her leadership resulted in advocacy at the United States Capitol in Washington. She holds a master's degree in social work from Wayne State University. The next person I'd like to welcome is Ms. Erica Nikolic, who is a director, producer, and writer. She started her skills as a litigation lawyer in New York, in San Francisco, and California. She has a passion for social justice and underlying love for film, which inspired her to launch her production company, Pavo Films. She thrives on unearthing injustices in her community and mindfully developing projects that initiate positive change in society. She has produced, written, directed several short films before starting the production on her first feature, Let There Be Life, in 2009. And our next finalist is Felix Valbuena. Dr. Valbuena is the current Chief Executive Officer for Chaz Center in Southwest Detroit. As a bilingual and bicultural physician, Dr. Valbuena is committed to providing culturally proficient care in one's native language to ensure better understanding of and compliance with medical treatment. He's an active supporter of federally qualified health centers, currently serving as a clinician representative on the board of directors of the National Association of Community Health Centers, and as a board member of the Michigan Primary Care Association. And so I want to welcome all of our panelists. And I also want to state that we are welcoming questions through the Q&A feature. So I'll keep that open and we'll refer to the questions from any of the people participating and viewing us today. But I'll start with one of the questions that I have, just to kind of level set a lot of things. You know, there's lots of talk about, you know, health, about quality of care and equity of care. I want to kind of explain to our audience what's the difference between health equality and health equity. And I'm wondering if Ms. Davenport Hatter would be interested in tackling that first.
Yeah, sure. Thank you. And so when I think about equality, I think about opportunities and services that are available to everyone. And when I think about equity, it's about making sure that people have realistic access to those opportunities and services. For example, making sure that there are high quality healthcare facilities in communities where people may have transportation barriers to drive outside of their communities to get care. And while at these healthcare facilities, you know, are there providers who speak their language and understand their culture, which in essence is used to for their plan of care. And so if you think about those images that we see on equality versus equity, especially the one with the bicycles. And so everyone has a bike. However, you know, the bikes were not designed for people who couldn't reach the pedals, or even for those with physical challenges who are not even able to get onto the bicycle. But everyone had equal access to a bike, right? And then there's the one image where there are people who are looking over a fence at a baseball game. And so each person was a different height, and some had boxes to stand on so they could reach a point where they could look over the fence to see the game. However, if you remove the fence, everyone, no matter their height, could see the game. And so the fence was the barrier. And when we think about it, when we remove barriers to access, only then will there be true equity.
Thank you very much. And I'd like to do a follow-up question to that, to any of our other panelists or any of our panelists. Can you give us like a real life example in healthcare where you've seen equality not lead to health equity? Anyone?
I can start. I think it's a big topic, and what is very important in these topics of unconscious bias, and especially understanding the stereotypes, and especially understanding the differences of culture and races. So, for example, can tell even for myself, I can look like a white person, but in the cultural setting, I'm a Latino, I'm Brazilian. And there is also some people that, there is one famous person, like if you are familiar with, oh my gosh, it's Afro-American, actually he's a Nigerian actor, and he said that Emmanuel Echo, his name, he's Nigerian, and he said that my culture is Nigerian, so it's and my race is Black. So it's very important to understand in a health system and be careful about this unconscious bias. Even instead of a stereotyping, is really understand who is the person in front of you.
Yeah, thank you. Anyone else have real examples of where giving equal care did not lead to equitable care? No? Okay, well, I want to transition to my next question. As you're speaking of biases, how does the spectrum of implicit bias all the way over to discrimination impact the health of individuals? And I'm wondering if Ms. Davis would be interested in starting with that.
Absolutely, and thank you for having me today. I think probably the most familiar or recent event of Dr. Susan Moore from Indiana is a great example of where that implicit versus really that overt bias is taking place. For those who are not familiar with the case, Dr. Moore is a physician, and she recently died of COVID-19. As a patient in another hospital, she had continuously asked for pain medication to make sure that she could rest comfortably and sleep comfortably. And she was continuously disallowed to have additional pain medication. They told her that she was, she's making it up, or that, is she a drug addict? All of those things that really contributed to her having a poor outcome. It wasn't until she went to social media to talk about her experience that her treatment was changed. And even in that event, she still died a couple of weeks later. She left that hospital because she didn't get really all the treatment she needed. She went back home. She felt more and more ill, went to a different hospital, still got the treatment she needed, but she had advanced so far that she passed away. And so when you think about things like that, really, is that some implicit, or is that really bias that is outwardly there? For my friends in Indiana, Indiana is probably not the most diverse state that we have. So there are some implicit biases that I'm sure are occurring there. What I think is one of the other things that we have to think about in implicit bias, it could also be seen as a positive, but not really. So if you hear the thing about the strong Black woman, that Black women can endure pain, or Black women are stronger than other people in the world. And so why is a pain medication needed if someone has a high tolerance of pain? And while that can seem to be like, yes, we like to consider ourselves strong Black women, that doesn't necessarily equate to we don't need medication. So it's things like that. I also think about diabetes healthcare. When you say, well, just have a better diet, don't eat so many starches. And we have food deserts in urban areas. Even though that's not necessarily an ethnic thing, it is socioeconomic. And so how do you reverse that stereotype of people saying you eat such a poor diet, no wonder you can't get your blood sugars right, or things like that. And I find that to be very, very disheartening. And even on a personal level, I have 2 sons with developmental disabilities, with autism. And boy, do you have to advocate for them in the, in the strongest way possible. I am very fortunate that I have a great insurance program, but I also fear the day that I'm not here and what's going to happen to them and how are they going to get advocated for. So there are a lot of things when it comes to implicit bias and just that whole range of whether or not it can help or harm a person, and whether even the overt discrimination. We see that that can happen, but the implicit or very, less understood bias that we all have can be a negative point to getting great health care.
Thank you, Ms. Davis. I really appreciate that. And I want to follow up on that question. I really appreciate you bringing up Dr. Susan Moore, who's actually a graduate of the University of Michigan Medical School. So she spent some time here in Michigan. So it brings things close to home, the fact that she died from COVID-19. Some of the things I noticed from her death and from watching her videos is that she was not heard and she wasn't believed and people didn't validate her experience. How can providers help center the care with the patient to validate their experiences and their cultural identity? I'll start with Fleischfresser, yes.
Yes, thank you. Thank you, Dr. Brown. I want to bring another diverse community here, if I may. I have the opportunity to have great conversation with a few American Asians clients in these last few days. And one of them specifically talk about the importance of don't measure. She used these terms, don't measure diversity. So when we talk about diversity, it's really to see all the communities, all the differences in these communities and what is that is behind each one as individual. So it's looking to seeing, we cannot measure as we are, I talking with this client that she was in tears of what happened this week with the Asian American community. She said, I can't focus working. I don't know what to say with my kids. And I know that Afro-American community had a lot of pain with so many things that happened in the years, especially last year was a big one. So it's really, really important for us as a diverse community, understand and be empathetic with each other, because we cannot measure diversity and we cannot measure pain. It's really to see each one as individuals.
Yeah, thank you.
If I may.
Yes, please.
Oh, I was going to say very similarly, my son is also autistic, and from a very young age, I knew there was something off. And so, I've never thought of it in that context until Dr. Davis mentioned this, but from when I presented to my doctors and then he was tested and tested, the final outcome was, it's personality. It's lack of structure in the home. And I said, lack of structure in the home will make my son go under the table. So many things that we, and at that point, I didn't, until those words were presented to me as the reason for his condition. And, for many, he was recently diagnosed, but I had to continue to say, I want my son evaluated properly, because what would happen is in 2, 3, 4 years, he'll become a disciplinary problem. Then he'll have an outburst, there'll be behavioral issues, and he will be tagged as the disruptive kid that needs medication, or, he may have, an aggressive episode. And then what do you know? Oh, there you go. Yeah. Juvenile detention center, who knows? But that's where it starts, from the young age when they do need these types of interventions and supports. Are they getting them, and who are they giving them to? That's where equity comes in. They're allowing them in so many areas and for so many people, but for others, they're barring them from obtaining them for, just because my son may be cognitively higher, he may perform cognitively higher, You know, he almost missed having his services, and boy, oh boy, what a difference that would have made in his life.
Thank you for sharing that.
Mm-hmm.
And anyone else have any thoughts? I want to thank Ms. Fleischfresser for bringing up the recent, you know, increase in escalation in anti-Asian racism and inequities that might exist there as well. We need to all stand up in solidarity against, you know, all forms of inequities, all forms of racism, all forms of hate. So thank you for bringing that up. I want to follow up on some of the things that I think Ms. Nikolic was getting at and direct this question toward her. How can we empower patients and families to be self-advocates for health equity?
Well, for me, and you know, going back to the project that I'm working on, and by developing this narrative, what I really hope to achieve is to create an urgency, to create that urgency in our community, the urgency that we need to be 100% invested in our health and committed to knowing everything we can about our conditions, educating ourselves, even when, you know, we are presented with a situation. You can't just walk into any hospital. And this, you know, the situation with the doctor is particularly concerning to me because you would think she would be the strongest advocate for herself. And when you walk into a situation, what I really want people to learn from this film and from anything, the implicit bias training or anything, the patients, you never know what you're going to get. You know, wherever you are in this world, when you walk into a hospital, you don't know who will present in front of you. You know, you have nurses who are, you know, working long hours trying to do their best, but you also are presented with healthcare professionals who, for the lack of a better word, you know, have no interest in utilizing the training that they've received. So you have to be absolutely certain that you are going to speak up when you know something is wrong. You know, here's an example. I had, you know, I was in a hospital in Detroit and I was filming, and, you know, the patient was sleeping and a nurse came in and she had a wrist on her band that says, you know, restricted, you know, extremity, you can't pull blood from here or something. It was the red. And the nurse came in to draw blood from the arm with her fistula in it. And she said, well, you can't draw blood from this arm. And the response was, why? And there was an exchange and they go back and forth. And, you know, she unleashed this fury of, you are responsible for knowing these things. What if she was sleeping? You know, what are the consequences of something like that? You know, that's all on film. And for her, you know, if you're a patient that presents yourself and you're just, do with me what you will, you have to, there has to be an urgency to take control of the autonomy of your body and to have a very clear understanding of the healthcare you deserve and that should be delivered in all across all boards. If you walk in to get your COVID shot, whether you're going to, you know, get your transplant services with the coordinators, you have to be one step ahead and stay on top of it. You cannot be relaxed. So, you know, we start with things like art. We have to, you know, meet people where they are. You know, if it's, you know, whether it's in the communities, if it's people love art, we have to come at it at so many different levels. And starting the conversation, you know, excellent organizations like MOTEP, they are doing the grassroots work, like Ms. Hatter as well, and, you know, Ms. Fleischfresser, they're all doing the groundroots work. We all need to just get in the communities and make sure that we're figuring out the points that are going to connect with individuals on a very unique level. So my thing is art. And so that's why I figure the narrative, changing the narrative and provoking by showing these visuals will be so provoking that people will sense the urgency to be more, just have a very strong knowledge of themselves and their body and just not let themselves be pushed around wherever they go.
Thank you. And I'd like to follow up with Dr. Valbuena from a physician point of view. How are you helping to advocate that patients advocate for themselves for health equity?
Yeah, so it's a constant sharing of information and education about chronic disease, about preventative care. Research constantly continues to show that a dollar invested in education goes much, much further to improve healthcare than a dollar invested in healthcare. And so, you know, at our level here at the center, all of the care team is constantly working to educate, share information so that patients, as part of their care team, are making decisions based on accurate, evidence-based information that they feel confident giving an opinion and working to improve their health and quality of life, because we are at every single level educating, informing with data that you know, they can use to improve their health. And we advocate in the community for the schools, constantly working with them to improve health and have our community value and continue to work to stick with the education, because that ultimately is what's showing to have a bigger impact on overall health than just what I do in the exam room.
Thank you very much. I want to go to, there's a question in the Q&A, and if others have questions to put in the Q&A, please do that. The question reads, there's so much work to be done for us to achieve justice in healthcare for our society that it can seem overwhelming. I would be interested in hearing the panelists' perspectives on where we should prioritize our efforts and resources to make the most impact.
I can start with that. And so I think that it starts with ourselves. And so biases are normal. It's natural, it's human nature. But we have to understand how implicit bias, it drives decisions, policies, you know, and actions. And so we need to be a bit more introspective and think about, you know, how have we impacted, how have we allowed our implicit bias to impact, you know, our decisions, and how have they harmed others? You know, and we think about intent versus impact, you know, and so, and we know that impact is what really matters. And so just taking a look, starts within, taking a look at ourselves, really having a moment of addressing our own implicit bias and how can we manage our bias so that we are not causing harm. And so I think that when we're able to sit back and lean into, you know, that type of introspection and not allowing that guilt or shame, you know, shadow our ability to move forward, but, you know, doing that acknowledgement, having some self-compassion, doing some self-caring around that, and moving in the right direction, because it's all about making sure that, you know, those that we serve or we impact has access to health equity. And so addressing that and moving forward, I think is the best start.
Yeah, great.
And also, oh, go ahead, Andrea.
Yeah, thank you. Very briefly, I want to add to that. I totally agree with Anjanette said, and also what Dr. Valbuena mentioned before. This is always start with education. We need to educate people with these languages, like this vocabulary, as I call that. This is like what Erica was saying. This is microaggression. This behavior is unconscious bias. I'm talking with my clients, not also just Asian people, but Indian people, American Indian people, that they everyday basis. And it's about educating people that this is unconscious bias, this is microaggressions, because we don't know what we don't know. So it starts with education and self-awareness, as she said.
Ms. Davis?
Yes, I wanted to say this also. We also need to consider our own mental health. Mental health is something that we don't necessarily talk about. I know in the Black community, sometimes seeking mental health services is shunned upon. You know, you pray about it and you pray to your leader about that, your God about that. But, you know, sometimes you need that social worker, that psychologist, that person that can really help you think about that. I think that's something that, again, is a repercussion from implicit bias. One, there are not a whole lot of Black physicians or psychologists out there. We need to increase that a little bit more. Our social workers are outstanding, wonderful people that are highly underpaid. We need to increase the levels of social workers out there that can help our communities. And then just really say, do all people in these underdeserved or in these communities even have access? We give services, we give the health care, but do we also support with the mental care? In the transplant world, I know if people have been on a list for a long time, that's a lot of things going back into your mind. And even if you are fortunate to get that transplant, your life still has to do some changes, and you have to do some mental work in order to adjust to a very new lifestyle. So I think even mental health needs to be addressed very much in order to progress forward.
It goes along with the social determinants or social drivers of health that looks at access to the healthcare services, education, transportation, language. CHAS employees mirror our community. You have to engage the community, and the providers, the services that we're providing have to be by individuals that actually mirror the community that we're serving. Many of our employees live in the community. And so that's a part of the testament why we're starting our 51st year of service to the community, is that you build a trust based on your ability to engage, to meet individuals where they're at, and continue to things as simple as providing services in their native language. We make a very concerted effort to hire individuals that can communicate in Spanish, whether they're Latino or not, because the majority of the patients that we serve, that is their language choice. So those social determinants or social drivers are very, very important in making sure that the care that we are giving is of the highest quality and meeting the needs of individuals in the community. As a provider in the exam room, sometimes it's a little depressing after all the years of schooling that I had. On my best days, the most that I'm going to impact the overall health and wellness of the individual in front of me is about 20%, because that other 80% are those social drivers and those social determinants of health. So CHAS and other federally qualified health centers across the country have acknowledged that, and all of the services that we provide help mitigate and help provide a positive impact for those social determinants and social drivers at the same time that we're providing high quality medical care.
Thank you for that.
I wanted to jump in as well. I'm glad that access was brought up, because that's a huge part of the social justice aspect of what I'm trying to dig into with my film. And thinking about the pandemic, and I was shooting in New Orleans up to and through Katrina, and the very worst of what you will see there were hospitals closing, people not having access to healthcare at all in certain parts of New Orleans. And even now, when you think of who's getting vaccinated, you have to think about when you're having natural disasters and you're having, pandemics, what's available to whom, and how can we move past allowing people to simmer and suffer in areas and not speak up for them? How do we make sure they're getting these types of services? Who's responsible for that, and who's responsible for them not receiving them? So when I look at what's happening now with the pandemic, it's very similar to what was happening, including mental health problems that people are experiencing during the pandemic. It's very similar to what was going on during Katrina, and how people were left to suffer without access to care for mental health issues or for the chronic illnesses that they had. They just had to wait to get services. Same during the pandemic. I mean, luckily my sister with cancer now, she was at the Cleveland Clinic, and they were spot on, but everyone doesn't have access to a Cleveland Clinic in their communities. So I think it's very important to talk about access, because a lot of people just don't have it.
Yeah, you all bring together so many important points that lead to inequities in healthcare. from the social determinants of health to bias, to years of discrimination and even racism. You know, I also feel that medicine was potentially built with certain people in mind. And some of the things that we need to do is be more intentional about our acts and make sure that those who are maybe of minority backgrounds or in underserved areas, that we're intentional and going out and reaching them where they are. Many of you are already doing that work. And so I appreciate all the work that you're doing there. Even with the COVID, you know, we need to reach out to minority communities with the vaccine, go to them, because there are so many barriers: transportation, language, fear, trust, you know. And so we, in order for us to overcome these barriers, we really need to work with the community and sometimes go to them with humility, and not act like we're here to help, but we really need to work in partnership with our communities. So with that in mind, I want to ask one more quick question before we close today's session. What does healthcare justice look like? And if each of you can answer that in one sentence, that would be awesome. I know it's a big one to ask, but what does health justice look like in one sentence?
I'll go first. And so health justice to me is when everyone who needs healthcare gets it in a way that's accessible to them.
Thank you. Who's next?
I would say that healthcare justice really goes to making sure we take care of each other and providing help to others when needed, and then receiving the help from others when we need it. If you do that, that can change the world. I'm sorry, that was 2 sentences.
I have about 5.
I would say health justice is providing services to the community, providing what they need, and not just giving everybody the same thing, but focus to their specific need.
Mm-hmm.
I would say healthcare justice is, you know, in short, not picking favorites. You know, everyone should be able to have their, you know, their time to shine, and just being able to have their accessibility to their life and ability to thrive, and have a doctor and health that's thriving and ability to live. How many sentences was that?
It's about seeing individuals as human beings, understanding their differences, and our differences, it's a gift. Diversity is a gift. The American, the world is beautiful because we are different. So let's appreciate our differences.
Thank you to all of you for all the work you do in the community, and for being part of this panel. I greatly appreciate it. This was an amazing discussion, and we're going to have to unfortunately close this, and I will pass this back off to Dr. Norman.
Great, Dr. Brown, thank you. And thank you to all the panelists for just a wonderful discussion, a very informative discussion. As we get ready to close out, I want to thank everybody who took the time to join us today for what I hope were 2 days of just great talks, stuff that gave us a lot to think about. We had a lot of discussions today that helped us understand the structural nature of some of the barriers that our patients and the community may find to getting both high quality healthcare and, as talked about in the last session, equitable healthcare. So thank you again to all the presenters today, to the organizers for all the work. Thank all of the attendees for your participation today. And we look forward to seeing you at the 12th annual Kountz Callender Drew Symposium in the near future. And thank you again for all your support. And I'm going to hand this back over to Alexandria, who's going to close us out.
Okay, well, thank you so much, Dr. Norman, for moderating today's beautiful discussions. What an insightful and inspiring presentation and panel discussion. Thank you for our talented speakers, panelists, audience for all of your contributions today. Just a friendly reminder, we value your feedback and to make sure that our symposium next year is even better. So please submit your evaluation by assessing the evaluation directions or using the QR code that's on the slide here or in your program booklet on page 11. Some important save the date. So next year, save the date for the next symposium, March 17th, 2022 at Children's Hospital of Michigan. We also are looking forward to our leadership breakfast next month, April 22nd. And then in the summer, the annual Life Walk and Run on Saturday, July 24th. This marks the end of our Kountz Callender Drew Symposium. We hope you take away the knowledge shared during the symposium to integrate within your career disciplines to improve equity and equality in health and transplant care. The recorded links will be sent to your email. Look out for an email by Monday with those links for the recordings. And enjoy the rest of your Friday and have a safe and wonderful weekend.